We have a really wonderful lineup today, talking about something near and dear to my heart. My name's Sharon Hillier. I'm a professor here at the University of Pittsburgh in the Department of OB-GYN, but I am also a PhD microbiologist who works on, obviously, infectious disease. So this past year and a half have been really, I think, eye-opening about how pandemics can affect communities, and that's something certainly we've all had an unfortunate experience of having firsthand, really seeing how this has affected all of us. We're going to have a speaker, Dr. Nicole Lurie. We'll also have a panel discussion from our colleagues Maureen Phipps and Harold Weisenfeld. But I'd like to start by introducing Dr. Nicole Lurie. She's currently the strategic advisor to the CEO and response lead at the Coalition for Epidemic Preparedness Innovation, or CEPI as it's known. She's also, in her spare time, a senior lecturer at Harvard Medical School, a member of the research faculty at Massachusetts General Hospital, and professor of medicine at George Washington University School of Medicine. I have to confess, I can't quite figure out how you can do all of those things at once. But nonetheless, one of the reasons that we're so thrilled to have her with us today is that she served for 8 years at Health and Human Services as the Assistant Secretary for Preparedness and Response. And in that role, she led the Health and Human Services response to numerous public health emergencies, ranging from infectious diseases to natural and man-made disasters. And she's responsible for many of the innovations in emergency preparedness and response. Dr. Lurie has chaired the Public Health Emergency Medical Countermeasures Enterprise, which is a government-wide organization responsible for the development of medical countermeasures, including vaccines against pandemics and emerging threats. She, in her other spare time, still manages to practice clinical medicine in a community clinic in the Washington, D.C. area. So she's an amazing resource. We're really thrilled to have her with us, and we look forward very much to your comments, Dr. Lurie. So welcome to the Magee Summit.
Well, thank you, and I'm so disappointed that I wasn't able to join you in person, either last year or this year, but I'm delighted to be here and have the opportunity to talk to you. So I thought I might just frame my comments a little bit with my experience working in government, just to say, good response to any kind of crisis really depends on strong day-to-day systems. You can't have systems that you build and stick them in a closet and think that you can dust them off in a crisis and that they're going to work. But also that if your day-to-day systems are rickety, your response is going to be rickety. And we have seen that particularly in our healthcare, in our public health system, and frankly to a large extent in our health delivery system as well. And we've seen it as it relates to the underlying health of our populations in the US. As you think about the morbidity and mortality from COVID in developed countries around the world, and you ask ourselves why we're doing so badly, we're starting with a really healthy population, and probably the most obese population when it comes to high-income countries. As we all know, our experiences have also highlighted really critical structural issues that disproportionately impact low-income people, people of color, or women. So in every disaster, people judge how bad things were by how they recover. And so I guess a question for us is going to be, will our country or the world have the will to address the day-to-day systems that have underperformed, some might even say failed us so badly? And how do we build a national resilience plan? Today, I'll just talk about some of the big buckets of activity I think that are needed. Public health and science, the healthcare system, science response overall, our social and economic system recovery, and then leadership and communication. Then I'll try to highlight some particular issues related to women, given the nature of this conference and this audience. And just to say, I think I'm going to focus mainly on domestic issues, but as I am deeply, deeply involved, as you've heard, in global vaccine development and our global response system, I'll also make some comments related to that. So first, let's think about public health and science and where we need to go. Surveillance, or the ability to know what's happening and predict likely scenarios, whether global, like animal spillover, or domestic, where we've been flying blind through much of this pandemic. We need, going forward, if we're going to prepare for the next pandemic, to really seriously up our game here. Having said that, while it would have been good to do a better job predicting this, I'll say we did. And novel coronaviruses, other than pandemic influenza, were at the top of the list of things that would potentially cause a global pandemic. And it would have been good to have earlier notice. Yes, it would have been great if China had let us know this was going on well before they did, but I'm also going to note that we as a country didn't act on the information we had. And so that if you're going to get that kind of notice and do that kind of surveillance, you have to be ready to act on it. I don't think, in this case, that surveillance and early notice, early warning, were our biggest problems, but yet they have to be addressed and fixed going forward. But I will focus here for a moment in the US on our public health system, not just the CDC, but the entire system. And to say, and I think we've confronted this now, it's been really rickety and underinvested in for a long, long time, and poorly equipped to respond. We've seen that. And as I said, I think the last major crisis I led the response for in government was the Flint water crisis. You can disinvest for a year or two. Sooner or later, it's going to come back and bite you. And we have had a lot of disinvestment, and it's come back to bite us big time. We have antiquated and fragmented data systems, disconnects with the healthcare system. We don't have anything remotely resembling universal patient identifier. We can't link surveillance data, testing data, immunization data, hospitalization data. These are all like in separate data silos and parallel tracks, never or almost rarely to meet. We don't have the ability to ingest and process and use the various COVID data streams we've had. And we've had really, really, I would say, dramatic underuse of things that are really commonplace now in business and industry in our lives, like artificial intelligence and machine learning. Fixing all this is going to require new investments in technology from the end to end. And I'm optimistic that the American Recovery Plan and the infrastructure funding that's going to come about will provide some funding to do this. But we need a fundamental policy thing. And we need to rethink the policy and the legal issues that are involved in reporting streams of data, who owns what, who can and who must share what, and how best to do the job for the population while we maintain privacy protections for individuals, just as one example. Also, we've got to confront the public health workforce, which was aging out before COVID, and now has been either quitting in droves or people are just leaving because they are under so much threat and assault in many parts of this country. We've got to rebuild it, we've got to modernize it. People need new skills, including really new skills and leadership in public health. New skills in public health leadership. We've seen that leadership, communication are critical. And I'll say a little bit more about that in a moment. We've seen some really great examples of public health leadership at a state and local level. But I would say strong leadership is not a great attribute that you see all over in public health. By and large, our public health entities, federally and around the country, didn't stand up and didn't withstand the kinds of pressures they were facing and lead. So leadership is something that we have to build. I am absolutely convinced it can be taught, but we got to do it. And then other aspects of our public health system that I want to highlight, the really mundane, financing all the way down to the local level. It takes like 9 months for money to go from Congress through OMB to HHS to CDC to state and local governments. And then local governments have to convene their city councils, their state legislatures, whatever, to be able to spend any of that money. The whole thing's over by the time you start. We gotta do a whole lot better than that. Also, in the public health sphere, all of the non-pharmaceutical interventions, we certainly can improve the science of all of these. But as time has gone on in this pandemic, the problem's been less about the science, and I'll say the science about masks notwithstanding, than it has been about the social and political challenges and how they were implemented, and the politicization and misinformation. Our social systems, as I will just note in a minute, were not adapted for people to be able to adopt the non-pharmaceutical interventions we wanted them to. Stay home while sick, don't go to school, don't send your kid to childcare. So all of those things. The other area where we've got a lot of work to do, although we could build on day-to-day systems a lot better, is vaccination planning or countermeasure distribution planning, whatever those things are and however they are going to work. Let's talk a minute about the healthcare system functioning. The lack of integration in our healthcare system and fragmentation in our healthcare system has led to incredible inefficiencies and challenges with meeting the surge demands that so much of our healthcare system experienced. Again, a lot had to do with the lack of real-time situational awareness, who had what and who had how many patients and where they were and all those things. But a lot of it also had to do with really big disconnects in our healthcare system between nursing homes, outpatient departments, emergency departments, inpatient departments, post-discharge, and the inability to divert public health and medical care resources where they were needed to manage the term. Over time, we started to see what looked much more like universal coverage for COVID, but the lack of this at the beginning kept many, many people from getting care and probably spread a lot of disease. And now we are moving back to business as usual in COVID. And what is that going to do for people's ability to seek care, get care, spread disease? So what is it that we want our system to look like in the future? What do we want coverage to look like? How do we want systems to be integrated? How do we think about healthcare costs? How do we think about the workforce and people practicing at the top of their license? And what do we do about this workforce that is so incredibly burnt out that they just want to leave healthcare when our country really can't afford for that to happen? Next area I just want to touch on is science response, because this is another area where I feel like in some ways we did really well, and in other ways we've got a lot of work to do to prepare for the next pandemic. Whether it's from the end to end, from discovery all the way to delivery. Where can we do better? We've had enormous success, as we know, in the development of vaccines, and we all celebrate very much the development, particularly of the mRNA vaccines. Although I would note that the US got off to a really slow start in this regard. It wasn't until April or May when Operation Warp Speed started that people really got going, other than early work with Moderna on mRNA vaccine. Part of that was the lack of a standing emergency infectious disease fund that was in place to be able to activate in early January when this all started. And part of it was about political issues and acknowledging that we were having a problem. But we got work to do on a science response. Places where we could have been much more prepared to execute a research response would be in research agenda setting. This is where issues about children and pregnant women really would become a forethought and not an afterthought. WHO did it, the US didn't. Pre-positioned research assets, a clinical trial infrastructure with novel design and leadership, so you're not doing hundreds of studies that are ineffective and can't yield results. Pre-positioned social science research. And now, in this world that I live in vaccines, there's a huge push for what's termed the 100-day mission. Okay, so that is to say, from the time we recognize a threat to the time vaccines are ready to go, how do we do this in 100 days? So think about science response that has to happen. And I also think about pregnant women in that context and how do we consider them. Social systems, let's acknowledge the fact that a lot of the problems are not scientific. Our societal systems, as I said, are not well adapted or thought through. Economic security, sick leave, childcare, education, internet access, food and housing security, all of these amplified inequalities of race and ethnicity and gender. And if we want to think about pandemic preparedness in the future, these systems need to change. Obviously, many of us think they need to change for lots of reasons, but a really big one might have to do with not having all of the breakdown in dysfunction, particularly in addressing economic security, childcare, and sick leave that we have. And ultimately, all of this stuff is related to trust in government and the ability, I'll come back to, for people to comply with the things you need to do early on, especially in the non-pharmaceutical interventions that you need before your countermeasures get there. In recovery, time to be designing the future we want. I don't for a minute want to ignore or belittle the challenges we have, but we cannot squander this opportunity either to create a world-class public health system, to address our social infrastructure, or for right now, to address the pressing mental health or behavioral health and emotional needs of our country. And finally, leadership and communication. I don't want to politicize this, but I do want to make a few points because we all appreciate how critical this is, and it is tied to trust in government. Turns out trust in government is one of the biggest global predictors of a country's ability to control a pandemic. And again, in the US, trust in government was low, and we have done a really poor job. And I'll just say along these lines, going forward, we need to make it expected and safe for our public servants to speak out without fear of retribution when they see something wrong. Let me just make a couple of comments about where I think we need to go, particularly for women, because obviously this pandemic disproportionately impacted women in the workforce, women who are childbearing age, and women are bearing the economic brunt of this, the caregiving brunt of this, the mental health burden of this, and many indirect burdens both here and around the world. Two I want to highlight in particular. One is long COVID.
I'm gonna go stand there.
But we've got really urgent work to do. And the other's thinking about if we're really going to do vaccines in 100 days, how do we start thinking now about safety and effectiveness and development of vaccines that are going to be suitable for and safe during pregnancy. And finally, let me just note that in the US, we were pretty fortunate when it came to all of this stuff. The US government, it does surveillance, it funds basic science, it funds countermeasure development, it manufactures the vaccines, it buys the vaccines, it distributes the vaccines. The rest of the world isn't put together that way, folks. And in the rest of the world, it was nobody's responsibility to do late-stage clinical trials. It was nobody's responsibility to buy raw materials to make vaccine, to manufacture vaccine at risk, to let companies know that if they made vaccines, somebody would buy them. It was nobody's responsibility to buy them, allocate them, distribute them around the world. So we found ourselves passing the tin cup in the middle of this pandemic every step of the way. Passing the tin cup doesn't work. Going forward, there needs to be a really clear global financing system with clear allocation of who's supposed to do what and clear allocation of responsibility so we don't let countries around the world down. And because at the end of the day, how well the rest of the world does is going to have everything to do with how well we do. Why don't I stop there? Thanks.
You couldn't hear the rapturous applause, but it was, or maybe you could, I don't know. We're very spread out in a very large auditorium, but I want to thank you so much, Nicole, for your amazing comments. What I took away from this is that in the report card of the pandemic response, Discovery for Science got an A+, clinical trials infrastructure got a C, and our ability to really anticipate the needs of women got maybe an F. And on that, I'd like to introduce our next panelist, and if you don't mind, I'd like to ask her the first question, and then I'll ask my colleague Harold Weisenfeld, who's with us, and I'd like to begin to ask people in the audience or who are attending virtually to begin to think of questions they might like to ask. Maureen Phipps is with us today virtually. She is the Chief Executive officer of the American College of Obstetricians and Gynecologists and Professor Emeritus of the Brown University School. She's the 40th president of the American Gynecologic and Obstetrical Society, or AGOS as we call it. Prior to joining ACOG, she served as professor and chair of the Department of Obstetrics and Gynecology and was the assistant dean for teaching in women's health at Brown University. And she's really a force unto herself. She has really established innumerable collaborations across the hospitals, departments, and state agencies to sort of destroy silos in how women have been seen. And I would like to pose a question, if I could, to you, Maureen. During any pandemic, there's lots of concerns, and I think this one has been particularly painful for those of us who work in women's health, because people who were planning to become pregnant and those who are already pregnant didn't have a lot of answers. I have to say, personally, I got more emails and queries from people who said, you know, I'm thinking about getting pregnant. Is it safe to do it now? I am pregnant now. Should I get the vaccine or not? I don't know how many of those messages I got. I'm sure you got 100 more. And you just heard from Nicole, we got an F in this. So my question to you is, how can we do better for the next pandemic to ensure that pregnant and breastfeeding women are not left behind, so we actually have data a lot sooner to inform those choices? Because we're hearing still, even today, people refusing vaccines when they're pregnant and are at higher risk of complications because the data was, I think we could have done much better in our messaging early. I'm really interested to hear what you have to say.
Thank you very much, Dr. Hillier and Dr. Lurie, for your comments. I really appreciate being part of this panel, and so sending a deep appreciation on behalf of ACOG, and appreciate that question. And I'd like to just kind of take a step back and get to the answer to that question, or maybe it'll really prompt some more questions. But no, we do need to prepare for a next pandemic or a similar public health emergency, and it really is going to be important. And this, Dr. Hillier, as you were alluding to, we need to learn from our experiences with this pandemic. As Dr. Lurie outlined, we need to look ahead and attempt to prepare, but that means taking time to reflect on these past 20 months and learn what went right, what went wrong, what we need to do differently in the future. So let me just give a little bit of a broad overview of kind of from a brief perspective here, and we'll focus on pregnancy for a moment and where we are today. There was a record number of deaths among unvaccinated pregnant patients in late summer and early fall. This was months after a vaccine was widely available. We need to understand that. We need to learn from our experience and make sure we focus on this significant patient population and those outcomes so that we can move forward in this pandemic, but also learn from it from a next emergency. So from the beginning of the pandemic, ACOG, and I will also say SMFM in partnership with ACOG, raised significant concerns about the impact of COVID-19 in pregnancy and worked to make sure pregnant individuals were considered at all points in the evaluation, prevention, treatment, and resources during the pandemic. Unfortunately, federal resources were not directly devoted to pregnancy early on. So to note, the original 2020 NIH National Institutes of Allergy and Infectious Disease Strategic Plan for COVID-19 research did not include pregnant and lactating people. Now, the updated plan for 2021 did rectify this oversight, and I think that is a very important thing to note. And I do think that will be something different as we would move forward. But that lack of attention and recognition early on about pregnancy and lactating people led to us, we lost ground. And our communities are still experiencing the ramifications, as you outlined some of them, Dr. Hillier. So ACOG brought attention to and called for the inclusion of pregnant and lactating individuals in clinical trials from the beginning. During the many months leading up to the development and authorization of the vaccines, we had both direct conversations and written communications with federal agencies. So that advocacy was strong from the very beginning. So as we think ahead, we can't forget that excluding or ignoring pregnant people can have devastating consequences for the health and well-being of pregnant and lactating people, but also our communities. So we see that, and you just described some of it, continued vaccine hesitancy among people contemplating pregnancy, as well as pregnant and lactating women and individuals. This is incredibly challenging to us at this point in time, and it does have an impact on all of our communities and has also highlighted existing inequities and disparities. So faced with the next pandemic, we must remind federal and state policymakers, agency officials, industry, researchers about what happened during this pandemic. We have to learn from our oversights and some of our missteps. So Dr. Hillier, I'll leave it at that and happy to answer additional questions on that topic.
Just one quick follow-up for you. You know, I've noticed now we're beginning to see this fantastic plethora of treatments for COVID. So if you do have a breakthrough infection, if you're vaccinated or if you're an unvaccinated person who becomes infected, you can potentially will have pills, protease inhibitors, other antivirals that you can maybe treat yourself at home and shorten your illness. But the other day when I checked, not a single one of those studies has been done yet in pregnant or breastfeeding people. So we're doing it again, right? We have the next we have vaccines, no pregnant breastfeeding people. Now we have treatments, doing the same thing again. So what can we do as a community to help people understand that people who are pregnant or breastfeeding are people who deserve the same kind of evidence other people deserve to guide their care? Because it's enough, but we're doing it again right now.
Dr. Hillier, I think you answered your own question there. We need to ensure that our voices are heard, and we can do that as a community. ACOG often will have a call to action, and it definitely helps that people are informed about these issues, and we continue to bring them forward. And the other part that really helps is patient stories. And so we are collecting them and being able to relate them in our conversations with federal agencies and others to ensure that, as you said, pregnant people are people and need to be included. So thank you for those questions.
Thanks. I'd like to, go ahead.
But this is also a situation where I think ACOG and women's health leadership and really clear communication is going to be super important. There are safe and effective ways for women who are, people who are pregnant and lactating to protect themselves right now if they get COVID. But we've got a bunch of unanswered questions about at least one of these antivirals and its safety in pregnancy and its safety in lactating women. And I think in the excitement about these new therapies, we're just sort of brushing them under the rug and just saying, oh, we don't really have any concerns. I'm not sure that's really the case, but it's going to be really hard and really confusing to help individuals who are pregnant understand. Number one, it's safe to get vaccinated. Number two, it's safe to get monoclonal antibodies. Number three, be really clear about what we do and don't know about these other therapies in a way that doesn't confuse the message for them. And that's going to, I think, have to be a leadership issue from the women's health community more than anything else.
Thank you for that, and I think that is absolutely the case. And just in case people in the audience, and Dr. Lurie and I can't see the audience, but for those of you in the audience, if you know, the ACOG resources are very clear and are updated regularly by our expert work group. And even if you just go to acog.org, the COVID-19 practice advisory is on the landing page, so you can get that information. That is a healthcare professional document, not the patient resources, but there are tools for patient interactions on that in that resource as well. So thank you, Dr. Lurie.
So our third member of the panel today is Dr. Harold Weisenfeld, who's a professor in the Department of Obstetrics and Gynecology here at the University of Pittsburgh. He also is one of the only people in the country who has a joint appointment or leadership role in a health department. So he's head of the sexually transmitted infection clinic at the Allegheny County Health Department. And in that role has had this interesting juxtaposition as an obstetrician gynecologist, but also in the COVID response at the health department. So Harold, can you share a few thoughts with us about your experiences over during this pandemic, and then I'll pose a question for you.
Sure. Thank you very much to Yoel and Sharon for having me here. While my interests generally lie in sexually transmitted diseases, and I also do COVID response, I will try and tie the two a little bit together in some of my words. Thinking about public health, as we've heard, is really the cornerstone of our country's protection against the spread of pandemic-related diseases. And we know that pandemics are to be expected. They're not random events, so to speak. We know as populations expand, as with climate change, we know as we push into habitats in the animal habitats and animal worlds, we're going to witness more pandemics, and we have to be prepared. And here in the United States, we've seen glorious advances, as we've heard, right? Vaccine development, relatively quick, manufacturing going quite quickly. But we've also witnessed a lot of inefficiencies or disappointments that really have highlighted the cracks in public health and reflect, I think, many years of overall neglect. And so I think we have to think about that. Personally, I can just think of our country's response. I was vaccinated very early, doubly vaccinated in January. The United States was one of the first countries to roll out vaccines, maybe shortly after the UK. Other countries were well behind. They had to also get ramped up. Canada, where I'm from, for example, took months to get their vaccine rollout going. But I was vaccinated in January. My 85-year-old mother received her first vaccine 6 months after I was doubly vaccinated. So that says something, but more importantly, after that, I think is actually more telling about the state of affairs in the United States. Right now, Canada, which rolled out its vaccine so much later than the United States, is now ranked 15th in the world in per capita vaccination. The United States, not even in the top 50. And so that's really telling. And I think a lot of this is, again, highlighting public health crises that we've been witnessing. So vaccine rollout needs to be done better. We've all witnessed kind of the fragmented and schizophrenic approach to scheduling. Do we remember our folks who are disadvantaged or living without internet access, trying to even schedule a vaccine appointment? If you didn't have a child who was internet savvy or a friend, you were out of luck. You weren't getting a vaccine. And the same thing could be true for test technology and availability of testing. We really had to ration our tests at the beginning. We had to take reagents from the STD field and move it over to COVID-19 diagnostics. So we compromised some of our very important other public health activities that are essential to the preservation of the health of our communities. So thinking about local public health needs, I think about many things, of course, and Dr. Lurie certainly gave us a really powerful overview of national, international, and even state and local needs. I think of kind of three things that I wanted to highlight today. One is contact tracing. Local health departments do a fair bit of contact tracing. It is, again, a cornerstone of what we do to limit spread of infections. Contact tracing is where you identify an infected individual or an individual affected with a particular disorder, and you reach out to their contacts and you inform them and get them tested and get them isolated, et cetera. And in this pandemic, well, firstly, even before the pandemic, we really had a bare bones contact tracing network in public health. We do it very effectively for syphilis control, HIV, gonorrhea, but we were really bare bones to begin with. And then when COVID hit, a lot of those resources had to be repurposed over to COVID. And very, very quickly, based on the the volume of cases coming through, most public health agencies, local health departments were quickly overwhelmed in terms of their contact tracing response. So only after that did these health departments mobilize and try to get volunteers, medical students who were not in class, nursing professionals, others would be brought on, trained, get up to speed. But that all takes months, and very quickly contact tracing got overrun with volume. So I think we have to really focus on rebuilding our health department infrastructure to get back to the basics of public health and infection control, like contact tracing. A second area I think that's really important is communication. We really need to think about doing a better job communicating, from health departments to providers. We need to have an efficient way of getting the same message out, a unified message, a simple message out. But we also need a good way of getting concise, clear messaging to the population. That's essential. We have to have our political leadership aligned with us. We can't have scapegoats or cast blame or otherwise politicize what really affects all of us, regardless of what political affiliation that we have. So I think that's really important. And I'm just going to mention that here at Allegheny County, we're very actually fortunate that our political leadership is tightly aligned with public health. We have a tremendous amount of support from our elected leadership, and I'm just very, very proud of that, being a citizen in Pittsburgh and a resident in Allegheny County. And then the last piece that I think is important for local health is data collection and analysis. And as Dr. Lurie also mentioned so eloquently, the IT infrastructure in public health was way inadequate for responding to this pandemic. The amount of infections reported, the amount of data flowing in, the cadence quickly overran what was already an outdated IT system. And so many health departments started to rejigger and develop their IT systems mid-pandemic. Instead of being ahead of the curve, we're already behind the curve. And so I think those three areas are critically important to local health. And of course, also alluded to, I would be remiss if we didn't talk about local public health's role in addressing health inequities, in not ignoring other very important comorbidities that are at epidemic proportions that make our populations less tolerant of these pandemics that are going to happen. Hypertension, diabetes, obesity, epidemic levels. Our population won't be able to defend itself as well if we have those other health concerns rampant in our communities. And then, of course, as we heard yesterday, the health inequities, the lack of access to health care, clinics not in the right places where people need access, where they can easily walk to get a vaccine or to get a test. And the other health inequities like air quality and food insecurity, all of those are intertwined and really are important to address and not ignore as we've shifted very little public health dollars to COVID-19. I do want to just mention some statistics and then I'll be quiet. We know that we've estimated to have lost over the last 10 years over 55,000 public health jobs in our country, a 20% decline in funding to public health. In the 1930s, 3.3 cents of every healthcare dollar was spent in public health. Today, it's 2.5 cents per every public health dollar. Public health is not sexy. We make a new discovery, new medicine, the patient gets it, and the patient's so cured and thankful to the doctor or the nurse for giving them that saving tool. But if we in public health prevent a viral infection that could kill somebody, nobody knows. There's no appreciation, there's no recognition. So we really need to focus our attention on rebuilding the essential public health infrastructure that we know that we need going forward. Thanks.
Thank you, Harold. And I would like to invite questions from the audience. If you're attending virtually, please submit those. But how can we bring sexy back to public health? I mean, I have been we've seen this erosion year after year in support for public health systems. We know it's here. I was talking at the height of the pandemic with someone very high at the Centers for Disease Control, and I said, I'm very concerned about our public health system. And he said to me, rhetorically, what public health system? And that's someone who worked at the Centers for Disease Control. So what do you think, Dr. Lurie? How can we put the sexy back into public health?
Well, I think we have an open window now and a once-in-a-generation opportunity to do this. I think public health can't travel on its own train track, never to meet the healthcare system, never to meet other things. So I think it's going to be an issue of healthcare leadership. It's going to be an issue of investment. And it's really going to be flipping the switch so healthcare leaders are able to really help people, both policymakers and the general public, understand what is the return on investment for them. What did we save for you in terms of lives? What did we save the economy?
Right.
What do we save in terms of absenteeism, in terms of schools open, all of these things? There are metrics that we all ought to use in our communities to communicate what the value was of the public health system, and frankly, where that value degrades when you don't invest in it. And I think we know more than enough now to be able to do that. But it's going to be about leadership, political will, and I continue to believe it's got to be through our data systems, and others doing a much better job connecting our healthcare delivery system and our public health system. So we've got some semblance of what's going on. This is the time.
Couldn't agree more. How about you, Dr. Phipps? How do we get sexy back into public health?
I really appreciated these comments, and I really think it's about collaboration and understanding the importance of really being in it together and recognizing that we all have a part to play. And I really think that thinking about partnerships, and I liked the real theme of true communication, effective communication, so that we are really able to reach everyone that we need to reach, and in terms that people understand and resonates with them. So that's the only thing I would really add at this point.
So we do have a couple questions from the audience. Our first question.
Hi, this is Mike Green. I'd like to make a couple of comments, actually, not a question, and bring to light, or to bring to this conversation some of the details about why we were sort of slow out of the gates in terms of getting vaccinations for COVID to pregnant women. First is that not just the vaccine, but the platform for the vaccine, being a nucleic acid platform, was novel. There were no prior nucleic acid-based vaccines that had been brought to market successfully prior to this. Now, this was an overnight sensation that was 20 years in the making,
Right.
But it was lucky that there was a coincidence between the maturation of the nucleic acid vaccine technology and the occurrence of the pandemic, number one. Number two is that when Pfizer brought their NDA to the FDA, they had not yet done the standard reproductive toxicology studies in animals that are normally requisite for any new drug application, just because it was on such an accelerated track. And those studies in animals even had not been completed until after the emergency use authorization. With respect to the new Merck drug, molnupiravir, the mechanism of action is again novel, and basically it is to promote the number of mutations in the virus to the point that the virus won't work. Well, how many pregnant women do you think want to take molnupiravir that increases the number of mutations to their fetuses for the first time without adequate data? So the details matter, and we can't forget that as we talk about what appeared to be us being slow out of the gates to get this technology into people's arms.
All of those issues aside, and thank you so much for providing that additional detail, I do think the lack of data just essentially meant that pregnant women were taking messenger RNA vaccines without any data. So it's, do we shift the burden to the woman and her healthcare provider, or do we shift it to providing a scaffold wherein we can proactively get this data by consenting women who are autonomous beings to enroll in clinical trials during pregnancy?
Yeah. Elise Hausberg from the University of Pittsburgh. Thanks so much for organizing this panel. I think for those of us that are clinicians in the audience, we're completely exhausted with having these conversations, right? Probably I would say 30% of my patients who are only pregnant or postpartum women are vaccinated. And you know, we use all of the tools that we have at our disposal to try to have these conversations with patients. We tell stories about women that have died during pregnancy that we've cared for. We talk about stillbirths. We do everything that we can, but I still feel like we're fighting an uphill battle. And when we listen to the reasons that our patients give us for why they're not accepting the vaccine, a lot of it comes from some of these discussions that we've, you know, these points that have been brought up. There was a lack of clarity out of the gates, right? There was, you know, pregnant women were excluded from these trials. Do you have any, you know, this is kind of a hard question. I don't think there's maybe an answer, but do you have any suggestions of other things that we can do to change our messaging? What can we do on, you know, outside of sort of the clinician level? What else should we be doing as a, you know, a community to try to promote vaccine uptake in our population?
Any thoughts to our panel? Dr. Lurie?
Well, it's such a tough question, and I don't know that any of us have the sort of magic solution here, but I might offer a couple of thoughts, and they're tough. The first thing I think for this community in particular is to try to make vaccination part of preconception care, because you still have an opportunity there. And I don't know the degree to which sort of we've really been able to focus on that. A second thing that I just continue to observe now is that people feel really cornered, and they feel incredibly judged, and they feel judged to the point that they don't feel like they can ask questions, because if you have questions about the safety or effectiveness of the vaccine, there's something wrong with you. So in the conversations that we have, you know, I've tried to think about how we can answer people's questions and sort of do these things in really, really non-judgmental ways, I think is terribly critical. And then obviously, as we've all talked about, at this point, this is like a whole country or a whole community effort, and figuring out with the segments of the community who it is that people trust as a source of information is critically important. Just in my own practice, I find people will really listen if we also talk about populations that are the really direct target of misinformation and where that misinformation is coming from. And it doesn't necessarily to people agreeing to get vaccinated then and there, but it has led people to be much more thoughtful about their sources of information and to come back and think about where it is that they want to get it. And so at this point in the game, I would think that those issues would be really important. And frankly, for, you know, two other things, pretty soon, like probably early January, we'll have a protein vaccine, if that makes anybody feel any more comfortable. But if somebody doesn't want an mRNA vaccine, they can still get a viral vector vaccine. There are still alternatives, right? And finally, also, just to, if they're not going to get a vaccine, what are the things that they need to do to protect themselves and their families are really important. And if they're not going to get one because they're pregnant, being sure that they are surrounded in their family by people who are vaccinated is also really, really critical.
Thanks so much. Dr. Phipps?
Thank you. And thank you, Dr. Hausberg. I wanted to just state that we're feeling for you, and this is exhausting. This is really hard, and so I want to acknowledge that. We are working hard to try to figure out additional resources or how to do this together to redevelop or shore up that trust that Dr. Lurie just spoke about as well. It's this isn't in it together, and I wanted to acknowledge that this is I understand that this is exhausting, and we're trying our best to support you.
Thank you. That actually means a lot. Dr. Yoel Sadowski, what's your question?
Thank you very much. Sharon, it's been a great discussion. Really, the four of you made some terrific points. One thing that the four of you noted in your comments is about communication. And each of the four of you have a very unique international angle. And I wanted to ask you about communication in other countries. Every country responded differently to the pandemic. Some success, some less, we saw some less success. And I guess my question is, can you think of any country, New Zealand, Canada, Israel, even China, can you think of any country that had a response, especially with regard to women's health issues, that we should learn from?
That's a hard question, Yoel. I'm trying to think about all my colleagues around the world and what they have told me about the response. And I'm not, at least in my mind, coming with a shining example of where we've done really well in terms of addressing these issues, in terms of how we care for pregnant and breastfeeding people particularly. But I'd be really interested, Dr. Lurie, in your comment. Do you think there has been any place where you've seen it done very well?
But it's a really great question, and again, I don't think I have a better answer than anyone else. I would say that there certainly are countries that have generated much better data about pregnant and breastfeeding people, and they're the same countries that have generated pretty good data on the epidemiology of this disease, on vaccines and vaccine effectiveness, and all of those. And we all point to the UK and to Israel, to Ireland, as some examples. I would also just note that there's, at least in the vaccine development community, and with the vaccine rollout, there are some really, really important discussions going on right now. UNICEF, for example, has really played an important role in vaccine confidence and understanding issues of vaccine confidence and vaccine hesitancy in low and middle income countries. And I think also learning from the experience during Ebola has played a fair amount of attention to pregnant and lactating people. As potentially one example, tomorrow, in fact, I was sharing with Maureen before this, there's a whole day-long workshop on maternal immunization for COVID and for immunization for other emerging infectious diseases, because of this whole recognition, both about the fact this has to be a forethought, not an afterthought, but also because of all of the issues involved about communication. But I wish I had a better answer to your question. I think it's such a good point.
Sure.
How about you, Dr. Phipps?
Thank you for that question. You've gotten my my thinking going as we move forward. FIGO is a really important partner here, and that the discussion around, and I was going to how pregnant people have been approached with vaccine or vaccination rates. That hasn't been widely shared among the leadership within FIGO, but I will bring it back and make sure that we address that collectively so that we can learn from it. I don't know that anyone is doing that specific work in a different way or with more success, but we certainly should learn from external partners as well. So thank you very much for that question.
And then finally back to you, Dr. Weisenfeld.
Well, I just have some thoughts, and it goes back to what all of us have mentioned. And Yoel, I don't have experience living in other countries other than Canada 30 years ago, and that was a different era when Canadian hockey they were winning Stanley Cups, not anymore. But I can't help to think that maybe the polarization that we're experiencing here politically, and I'm not going to point fingers at any one individual or any two individuals, but when governors don't align with their public health experts and send mixed messages, that's only going to hamper what Elise is trying to do in her clinic and try to gain trust. And so I worry about how our society is really becoming frayed and apart rather than together on this. And maybe these other countries like the UK, like Canada, they may have better trust in their healthcare systems. Many of them are socialized medicine, many of them have healthier populations in general, and they probably have more trust in their health experts. We, on the other hand, are battling sometimes, and sometimes those battles are insurmountable on an individual level. I can think of dozens of patients that I've like, whoa, okay, we're going to back up. You know, I tried to meet them halfway. I couldn't even meet them 10% of the way. So it's a struggle. But I worry about our society here and being fragmented and pulled apart. And we need to kind of, like I said, depoliticize public health.
So we're really at the end of our time. Yoel, do you want me to take one more question, or would you like me to close? Okay, sorry, we have to close now. But thank you so much for your wonderful presentations and sharing your time with us today. And please, all of you in the room, we need to join together to try to figure out how to do this better, bringing public health back to be an equal partner, a real partner to health systems everywhere, to increase better communication, and to do much better for the entirety of our society, including pregnant and breastfeeding people. Thanks so much.